Okay, well, here we go again, folks. I was unable to project the PowerPoint onto my TV, so I'm trying to do it between computers, which hopefully is going to work. Give me 1 second, and I'll set this up a little bit, and hopefully we'll be in business. Okay, alrighty then, let's see. Well, today we're doing personality disorders. They're classified as Axis 2. And again, I realize we haven't gone over the axis or axi, however you pronounce it. We'll talk about that in a lecture or two. Axis 2, they're not considered true psychiatric disorders. Axis 1 is true psychiatric disorders. Axis 2 are not true psychiatric disorders. Axis 3 are medical disorders. Axis 4 are psychosocial stressors. And Axis 5 is GAF, Global Assessment Functioning on a scale of 1 to 100. How do you handle things? Most of us function at about 80 or 85. People get admitted to the hospital at about 35 functionality and get discharged in an upward trajectory of around 65. Okay, here we go. So before we can talk about personality disorders, we have to talk about what personality is. So personality is deeply ingrained patterns of behavior which include the way one relates to, perceives, and thinks about the environment and oneself. Personality traits are patterns of relating to the world that are integrated into one's psyche. They tend to be unchanging throughout a person's life. Adaptive personality traits, they help a person meet their needs or adapt to their environment. On the other hand, maladaptive personality traits do not help people meet their needs, thus causing distress or impairment in functioning. So personality disorders, the person has more maladaptive traits that don't allow them to meet their needs. So definition of personality disorders: enduring pattern of inner experience and behavior that greatly differs from expectations of one's culture, involving maladaptive personality traits. Can involve cognitive dysfunction, for example, an inability to perceive self, others, and events. Active lability, that's rapid mood changes. Affective means mood, how you present your mood. And appropriateness and impulse control. As a general rule, these patients tend to lack insight. So they see nothing wrong with the way they view the world, which means they do not seek out therapy. Without this insight, it tends to be ego-syntonic. In other words, they're okay with it. Something that's ego-dystonic, the person's not okay with it. So these people think that they're perfectly fine, that it's not them that's the problem, it is the world that's the problem. All people possess some of these dysfunctional traits. For a true diagnosis, must see trait beginning in childhood or early adulthood. So this is an example of, as we spoke, most psychiatric disorders begin in late adolescence, early adulthood. Personality disorders can begin to be seen quite young, maybe 5 or 6. For example, a conduct disorder, this is a child whose conduct is belligerent, and they don't respect authority, things like that. That can morph into antisocial personality disorder, which is really a sociopath. Antisocial, and I want to make it clear, it doesn't mean that every child with conduct disorder becomes a sociopath, okay? But it can be morphed. What we're realizing now with a lot of things, with early intervention, we can really do a lot of good. For example, Asperger's and autism, they're learning if you can really work with this child at a very, very young age, you can lessen some of the symptoms of that disorder. So again, if a person did morph into antisocial personality disorder, that disorder, the person lacks empathy. They will hurt somebody and not feel any remorse. They lack a superego. Many times, if you look at a patient's chart, it'll list the axis 1, axis 2, axis 3, axis 4, axis 5. Axis 2, it'll say deferred, because the clinician simply doesn't have enough information to give this person a diagnostic label of some type of personality disorder. Again, as with all mental illnesses, it is on a continuum of degree and duration. all of us possess some maladaptive traits. There's no doubt about that. Again, I often joke as you guys read your book or listen to these lectures that you say, oh, there's my brother, there's my sister, there's my uncle. Okay, because all of us, and it might be, that's me. All of us possess some of these traits. So there are many types of personality disorders, but we're going to look at cluster A, B, and C, okay, as per the DSM classification, DSM-4. Cluster A, these patients tend to be odd or eccentric, comorbid with psychotic disorder, so they lean towards psychosis. Paranoid personality disorder tend to be suspicious and think of others are plotting against them, and I cannot help but think George on Seinfeld. George, if you look at George on Seinfeld, he's suspicious of others, that other people are out to get him. Schizoid personality disorder, these people truly do not desire social interactions. They tend to have poor social skills. They can appear cold or aloof with constricted affect, meaning they don't show a lot of joy or a lot of sorrow. Constricted. Schizotypal, these people tend to have odd beliefs or are superstitious. May have perceptual distortions. Again, they're on the low end of the schizophrenia continuum. Distortions like ideas of reference, I have it abbreviated IOR, ideas of reference, can be viewed as pre-schizophrenia. So if this goes on long enough, they will change your diagnosis from schizotypal to schizophrenia. Cluster B, these tend to be dramatic and emotional. Let me try turning off this light to get a little less glare. Okay, I'm back. I don't think it helped, but whatever. Okay. Cluster B, they tend to be dramatic and emotional, comorbid with affective disorders. In other words, they're comorbid with mood disorders. Antisocial, which I spoke about a few minutes ago. This is what society calls a sociopath, meaning they are against society. Sociopath, society, pathological. They lack empathy. There is disregard for others. They tend to be criminals. Minimal or no superego, like I said. So they truly lack empathy. I think I've spoken about a story when I worked in a hospital. We admitted a patient. We went through his possessions, and we found this very large knife, almost a machete. And we said to this patient, what is this for? And he looked at us with a blank face, no emotions, and simply said, sometimes you have to do what you have to do. I've only been afraid of 2 patients in my entire life, my entire career, and he was one of them. Histrionic, these patients tend to be excessively emotional. Hysteria, they tend to be shallow. They need to be the center of attention, tend to be flirtatious, and lack sensitivity to others. It's not to the point of lacking empathy, but they lack sensitivity to others' feelings. So there is a slight lack of empathy, but not to the degree of the antisocial. Cluster B continued. Narcissistic. These people tend to be grandiose. They think they're greater than they really are. They have a great need for admiration, a sense of entitlement. Again, there tends to be a lack of empathy here. Maybe not to the degree of antisocial personality disorder, but there is a lack of empathy and caring for others. Borderline personality disorder. This literally means the border between psychosis and neurosis. They tend to have a very unstable sense of self and relationships. Again, if you don't have a sense of self, how can you really have stable relationships? They tend to be impulsive and unpredictable. Affective, again, mood instability. Cannot tolerate feelings of abandonment. Inappropriate, intense anger. They can be manipulative. And cutting is often seen. They're angry at someone else, so they hurt themselves. So these people, the hallmark here is affective instability and feelings of abandonment. They don't want to be abandoned. And the simplest thing, a wife goes on a business trip, and the husband, when she's gone, tries to hurt himself by cutting, what we call delicate cutting, which is not said to be suicidal intent, but delicate cutting, many times on the wrist. And when he goes to his psychiatrist or psychologist, they say what happened, and he says, my wife abandoned me. Meanwhile, the wife went on a business trip to Chicago, which he fully knew about. But they take things abandonment. There's a very, very high incidence of abuse as a child. For example, sexual abuse. It does not mean that everybody that has abuse in their history becomes a borderline. The human body and the human mind is very adaptive, and people can work through this. Let's talk more about borderline personality disorder, because these are the people that are most commonly seen in the hospital. Although all personality disorders are hard to treat, borderline is probably the most difficult, as they, the patient in this case, tend to manipulate staff. They split staff between good and bad. In fact, working in a hospital, there was no smoking allowed in the hospital. The patient got admitted, borderline. I felt very bad for him, so he came up to the desk and said, Mike, please, do you have a cigarette? Do you have a cigarette? Please, Mike, do you have a cigarette? I need a cigarette so bad. So I gave him a cigarette, which I should not have done because it was against the rules, but I did. He said, you're the greatest, Mike. Mike's the greatest nurse in the world. So I was the greatest nurse in the world. Well, he smoked a cigarette, came back 20 minutes later, wanted another one. And I said, I really can't give you one. I'm so sorry. I don't want to lose my job. And then he said, you're the worst nurse in the world. Mike's a terrible nurse. So within 20 minutes, I went from the best nurse in the world to the worst nurse in the world. So let me go back one. He first made me the greatest and then made me the worst. So, right, he split staff between good and bad. There it is. They tend to place staff one against the other, kind of like your child might do, but daddy said, or this nurse said I could, you say I can, so you're the worst nurse in the world. They may report staff for perceived mistreatment. They may threaten lawsuits. They tend to make staff feel incompetent. All personality disorders do not respond well to medication. So it can be frustrating for the clinician to work with them when you don't see them improving, okay? When you work with someone who's depressed or has schizophrenia and you give them medication and you work with them, you literally see them improve over a couple of weeks. We don't tend to see this rapid improvement with personality disorders. So it can be somewhat frustrating, which really means you need specially trained staff to work with them. Okay. They get angry at others, so they hurt themselves. They're angry at their wife or girlfriend or boyfriend, whatever, and they, what we call delicately cut themselves, generally on the forearms. Okay. Again, the intent here is not to commit suicide. The theory here is they have emotional pain in their head. By cutting themselves, they now can focus, somaticize in a sense, they now can focus that pain on the cuts on their arm. Freud might say that they feel they need to be punished. I don't agree with that. I believe that they can focus on the pain of their arm. Another theory here is that when they cut themselves, they actually release some endorphins and actually feel better. You will hear staff, unfortunately, say things like, he or she is such a borderline, and that statement by the staff member is really saying, I am frustrated with this patient, they're not improving, they're not getting well, they're threatening lawsuits, or you'll hear something like, they're so axis 2. That really is a sign of frustration from the clinician. We don't want to do that, and when we hear other people do it, we have to say to ourselves, we don't want to do that. Okay? Yes, working with people, any sick person is frustrating. People are not feeling well. If you have COVID-19, if you have cancer, diabetes, when you're not feeling well, you might be a little irritable. We as nurses have to expect that. And I've said in a previous lecture, we should not take that personally. Okay, well, like I said, borderlines can split. Patient can not see that all people have both good and bad traits, or either all good or all bad. This is a little like your 3-year-old. Either see you as all good, idealized, that's called, or all bad, devalued. And I told you the cigarette story, which is at the bottom of the screen. Let's continue on. Okay, cluster C. These patients tend to be anxious and fearful, avoidant, A personality disorder, they're socially inhibited. They tend to feel inadequate. They're hypersensitive to others' evaluation. Notice it's underlined. It's a hallmark feature here. Thus, they avoid interpersonal situations. They desire relationships, but have a fear of rejection. So they avoid social interactions and intimacy because the fear of rejection is too great. Again, all people have a fear of rejection or humiliation. We all possess some of these traits, but this would be very strong with this personality disorder. Dependent personality disorder, an excessive need to be taken care of, i.e. dependent, need excessive reassurance, okay, which can lead to clinging and submissive behavior. These patients may very well be more prone to abusive relationships because they're dependent. They cannot live without this person. Obsessive compulsive disorder, obsessive compulsive personality disorder. It's not the same as OCD. It's on that continuum, but there are some differences here. There tends to be a preoccupation with orderliness and perfection. These people tend to be rigid and stubborn. They want to have things their way. Do not have full-blown obsessions or compulsions. I did some research into this. It is said that obsessive compulsive disorder, OCD, is ego dystonic. These people don't like it. They know the rituals they have to do of checking the gas on the stove 12 times before they leave is somewhat silly, but they're compelled to do it. It's ego dystonic. I have read that obsessive compulsive personality disorder is ego syntonic. These people see nothing wrong with their need for orderliness and perfection and their rigidity and their stubbornness. So it's a very interesting juxtaposition there that similar symptoms, but one views it as ego syntonic and one views it as ego dystonic. And once again, it is an interaction between nature and nurture, which literally means genes and the environment. Although in this case, it is probably more environmental than with any other mental disorders. And very important here, like I said earlier, is they do not respond well to meds, which can become the frustration here because nowadays we've gotten so good with medications that we see these miraculous recoveries with depression and psychosis. The prognosis of personality disorder. Prognosis is generally poor because these illnesses are ego-syntonic. Patient sees nothing wrong, so they do not seek treatment. That's a problem. They'll drive everybody else crazy around them, but they think that they are right. Long-term treatment is needed to undo past environmental causes, and again, poor response to medication with all of the personality disorders. Treatment here, psychodynamic or psychoanalytic. Again, when we hear these terms, we think of Freud. They tend to have a poor effect because the patients lack patience and insight. They don't have the patience to lay on the couch, so to speak, and discuss childhood emotions and feelings. Okay. Cognitive behavioral therapy, on the other hand, is most effective as therapy is very concrete and results are often seen more rapidly to help patients deal with cognitive distortions. So really, cognitive behavioral therapy is help teaching the patient how to view problems from a different perspective, different thoughts, and helping them change their behavior. Marsha Linehan, a very famous psychologist, I believe she was out of the state of Washington, somewhere in the early 80s, late 70s, I believe, developed what was called dialectical behavior therapy. It's a type of cognitive behavior therapy that helps patients deal with rapidly fluctuating emotions, improve personal skills, problem solve, and avoid self-harm. I guess it's on the next slide. Let's see. Dialectical behavior therapy. I do not see it there, but that's what it's called, dialectical behavior therapy. Group therapy might also be useful here. It can certainly help these people develop trust. It can offer support, as with all patients in groups. It can improve interpersonal skills, and it also may help them develop empathy. If you have a sociopath, personality disorder, being in a group, maybe someone in the group was mugged and they're crying, and this person may see that then when they mug people, that the person feels emotional pain. An interesting note here, when boys grow up with sisters, they learn empathy and have a less chance of antisocial personality disorders. Men by nature are more aggressive than women, probably because of testosterone. So when they or with their sister, they see the sisters being kind and caring, and they learn that. In fact, it is said that the root of all empathy stems from a mother's love for her child. So women possess empathy to a greater extent than men. Men can learn it, hopefully with kind mothers, and sisters are very important. But it's not as natural in men, empathy, than in women. Milieu therapy, this is the environment. Milieu means environment, meaning the hospital unit should create a community that represents the outside world. I think I've spoke about this in the past. It can use what's called a token economy. Again, I know when I worked in the Veterans Hospital in Northport, the guys, if they made their beds, took a shower, they were doing well. Of course, if they were not suicidal, they could get some booklets that could be spent at the local store downstairs in the VA. Okay, so they would get privileges. And that's really what the world's about when you think about it. You go to work, you make money, and you spend your money. These people work to get well, they take their shower, they make their beds, and if they're doing well, they can get a pass to leave the unit and go down and spend that money at the store. When problems arise in the therapeutic milieu, they are discussed in community meetings. I believe I spoke about this yesterday in the drug rehab, which some of you have been there, some of you haven't. Every morning there's a community meeting to discuss what are the issues in the community right now. Someone's drinking too much coffee, men aren't lifting up the toilet seat when they go to the bathroom, things like that. Well, there was a situation when I worked in a hospital, working in a drug rehab. In this drug rehab, the patients had to do the cleaning of the unit. Again, this is what we do in a home. We clean our home, right? Well, there was a patient who was assigned to clean the bathroom, and he took his bleach solution and slapped it on the floor and slapped it on the toilet seat. He did not dry that bleach. Well, the next poor guy that came in there to go to the bathroom sat on the toilet seat and thought he was sitting on just a wet toilet seat, but it was more than water, it was bleach. Well, he came up to me very, very upset. He was going to get this guy. They're out to get him. Somewhat paranoid. I reassured him, no one's out to get you. He wanted to know whose job it was. I said, I will handle it. So I went to the person whose job it was to clean the bathrooms, and I said, look, when you clean the toilets, you have to rinse off the bleach off the toilet seat, because bleach can give somebody a chemical burn, and somebody in this hospital did get a chemical burn. Of course, being a nurse, I had to have the patients lower their pants and examine the skin, and yes, there was a mild chemical burn. Nothing severe, but yes, some redness there. Okay, so medications. Again, generally poor effect. Benzos may reduce anxiety, but these patients tend to be prone to addiction, so we want to avoid benzos. If we're going to use a benzo, clonazepam, again, most benzos end in AM, also known as Klonopin, is the drug of choice as it's very long-acting. So let's talk about long-acting versus short-acting. Long-actings tend to have a long half-life. They don't hit you that quickly, and they stay in you longer. So Xanax has a very short half-life. It hits you rather quickly, probably within 15 minutes, 20 minutes, and it comes out of you in 4 hours, which means you have to dose again, which means it's more prone to addiction and abuse. So clonazepam, Klonopin, would be a drug of choice here. SSRIs may help. Again, there isn't a great effect here. They may help with mood regulation, some impulse control, because we know that when you raise somebody's serotonin level up, they tend to have better impulse control. They're less prone to frustration, intolerance, also may anger reduction and control. Antipsychotics may be used also to reduce psychotic symptoms, and antipsychotics, as we learned in the anxiety lecture, can also be used to treat anxiety. Hence, a better name for them would be major tranquilizers. Because again, when you tell somebody with a personality disorder or an anxiety disorder that you're giving them an antipsychotic, they're going to say, no way. I'm not psychotic. Okay, I'm not schizophrenic. So again, it's how the nurse presents this medicine to the patient. The doctor writes the prescription and moves on, goes to his private practice or whatever. The nurse's job is to teach the patient in such a way that they want to get on board for treatment. And again, the goal of all mental health treatment and all treatment for any illness is to give patients a better life. So again, nursing care, nursing assessment, on intake. First thing we want to do is assess for suicidal ideation or self-harm. And if they say they do have suicidal ideation, the next question we ask is, do they have a plan? If the plan is achievable on the unit, we put them on one-to-one. We call the doctor up, we write a note, the doctor comes up, reads our note, interviews the patient, and he'll decide whether to keep the patient on one-to-one or take him off. Either way, the nurse has done their due diligence. Okay, what is the current emotional state of the patient right now upon admission? Are they angry? Are they impulsive? And chances are, if they're getting admitted to the hospital, they are angry or impulsive or suicidal. Because as we've said in the past, there's 3 reasons people get admitted: suicidal, homicidal, or gravely disabled, meaning the psychiatrist or NP doesn't feel this patient's judgment is clear enough to let them leave the hospital, meaning they might try something like to swim across to Connecticut, and they're not good swimmers. Okay, we might want to ask the patient, how have they dealt with these feelings in the past? How would they like to help? How would they like to solve them now? So we get a feel of how did they deal with it in the past. Well, maybe this case scenario I gave you a few minutes ago where the wife went on a business trip. Maybe it turns out that in the past, the client used to go to his parents' house, but in the last year, the parents passed away. So now he has nobody to go to, again, increasing that fear of abandonment. A nursing diagnosis here: risk for suicide, anxiety, ineffective coping, disturbed personal identity, meaning they don't really know who they are, impaired social interaction, going on, especially with borderline, to disturbed thought processes, i.e. that would be psychosis. And again, that applies to borderline because borderline is the nexus between the neurosis and psychosis. Under duress, a borderline patient can become psychotic. Again, in reality, all of us can if we're under enough duress, particularly if we don't have sleep. General outcomes. What do we want to achieve? Well, certainly, like I've said, the symptoms that got them there, the data that got them there, we want that to subside. Maybe the patient gains some insight into the illness and its symptoms. Patient can begin to identify cognitive distortions. They're beginning to realize that maybe the way they're viewing situations is not accurate. Patient can identify more effective problem-solving skills. We can help them with that. Nursing interventions. Again, we have to establish a therapeutic alliance. Actually, might be difficult with this group of patients, particularly borderline and antisocial. We want to create that alliance by meeting with the patient briefly, and I've said throughout the shift, I would say out of every hour, we should try to be out on that floor as RNs and LPNs and nurses at least 15 minutes. We shouldn't be behind the desk all the time. Yes, we have nurses' aides that are out there and working with the patients. That's their job. But we want to get firsthand information. So I advise you, if you're becoming a psych nurse, to sit in the day room with the patients and watch TV, interact with them, maybe have time to play a game of cards or checkers or something. It shows that we care about them. We're not just sitting behind that desk. Okay, so we want to establish a therapeutic alliance. Again, I spoke about if they have a suicidal plan that is viable on the unit, we want to put them on one-to-one and inform the NP or psychiatrist. Does patient appear to be anxious or impulsive? Again, consider one-to-one. We want to assess for drug and alcohol problems. If you might remember, there's this little questionnaire, this little mnemonic called CAGE. Do they feel a need to cut down? Do they get annoyed by people talking about that they're drinking too much? Do they ever feel guilty? And do they need an eye opener in the morning? Again, anybody having a drink in the morning consistently probably has an alcohol problem. And the reason why they need to drink in the morning, as we've spoken about, is because alcohol has a short half-life. We can have written contract for behavioral control. In other words, the team can meet, as you guys have seen or will see in clinical. Everything is done as a team. The team meets every day and discusses every patient on the unit. The team can come up with a written contract for the patient to sign and agree that they will not threaten others, they will not steal from others, they will take a shower, they will make their beds, things like that. We can do a simple verbal no suicide contract. We can ask the patient, Mr. So-and-so, can you agree to come to the front desk if your suicidal thoughts get more severe? We want to help you here. You need to come to the front desk. That would be verbal. Inform the patient if they are still legally responsible for their behavior. Again, this is very, very tricky. Some patients feel that if they're on the psychiatric unit, that they are not responsible for their behavior, that they can hurt somebody and get away with it. That is not true. Okay, they are still responsible for their behavior, and if it ever went to court, a psych evaluation and a jury would decide that. When we get to the legal lecture, we'll talk more about that. Okay. Assist patient in identifying dysfunctional coping patterns and cognitive distortions that I've spoken about. Educate on more effective coping strategies, how they can handle things in the future, such as writing down thoughts and feelings, called journaling, talking it out. Maybe they can practice emotional control in front of a mirror. I had a patient get the wrong tray. He ordered grilled cheese and he got fish. He was very angry. He was going to throw this into the tray into the dietitian's face when she came back. And I actually told him, I said, throwing the tray at the dietitian will not get your needs met. And I have to be honest with you, sir, you look very, very angry now. And that's scary to people. I have to be honest with you. I'm a little afraid of you when I see you this angry. So maybe he could learn to look in the mirror and learn how to modulate his facial expression a little better. We want to assist the patient with assertiveness training. When I worked in the VA on the rehab ward, a great term we used to say was assertiveness is saying what you mean without being mean. In other words, letting your needs be known without aggression. Okay. We can offer PRNs only after talking to the patient. Again, if we always give the patient a benzodiazepine or something like that every time they're anxious or upset, we basically teach the patient, you cannot solve your problems. You will need to take this medicine forever. Now, I'm not saying we can't give them a medication after we've talked about their problems and what's bothering them. If they're still upset, we can give them a benzo. Of course, it has to be ordered. But I have found 90% of the time, if I give a patient or anybody 15 or 20 minutes of undivided attention, validating what they're feeling. Now, I might not agree how they're interpreting a situation, but if I validate that they are feeling a certain way, I have found that after 15 minutes or so, they calm down, they feel validated, and they don't need that PRN medication. Okay. Seclusion only for protection, never others. At the last resort, if somebody's out of control, it doesn't matter the diagnosis, is seclusion, which basically is a room that is just a mattress on the floor where they can't hurt themselves. It's never, ever, ever used as punishment. It's used for the protection of self and others. We want to provide immediate feedback for inappropriate behavior. Why is the behavior inappropriate? Explain to the patient. I had one patient who used to go into other patients' rooms, steal their cigarettes, and then sell them back to the patients for $1 each. Okay, that's inappropriate. We tell patients those are not your cigarettes, and it's inappropriate to go in anybody else's room and take their possessions. How it will not help meet their needs, that behavior. Provide appropriate alternatives. What can the patient do? How can they behave in the future? Again, I spoke about this patient who got the wrong tray. He was very, very angry. He threatened to throw it in the dietitian's face when she brought the other tray up. I said that's not going to meet your needs. when the dietitian brought up the other tray, first he said he didn't want another tray. The heck with that. I said, no, don't worry, I'll order it for you. I did. As soon as the dietary aide came to the door of the unit, of course, I went over there before the patient got there and got the tray and brought it in and gave it to the patient. Okay, let's go on here. We want to praise the client for appropriate successes. When we see them handling a situation appropriately, we can say, hey, that was good. You handled that well. You controlled yourself. Just like we do with our children. When we see them controlling themselves and acting appropriately, we give them some gentle praise. There's a thing called SET. S for support patient and their concern. E, empathize with the patient. Yes, I can see getting the wrong tray can be frustrating, especially if you're allergic to fish or whatever it was. Then we give them a truth statement. We present reality to the patient and offer other ways to deal with the situation. SET. Support patient, empathize, and give them a truth statement of how they can deal with this in the future. Well, I told you the story briefly. I'll let you read it on your own. That is the story about the patient who got the wrong tray. The nurse can assist the patient in developing a plan. If this happens again, approach the desk calmly. Talk to the nurses politely. Patient can practice this with the nurse or in front of a mirror, like I said. Throwing food at a dietary aid will not help solve problems. Again, politeness goes a long way. I interact with you guys, you interact with me, and we interact with politeness and professionalism. Let's talk about specific interventions for personality disorders. Paranoid personality disorders, we want to communicate clearly, minimizing any misinterpretation. We want to avoid chatting where patient can hear. In other words, talking as nurses, avoid talking where patient can hear as they may think you're talking about them. The nurses' stations are many times an area where the patients tend to congregate. Remember, they're living there. We don't tell them to leave the nurses' station. If we have something we want to talk about privately, then we go to an area that's more private. We don't ask them to leave. That's disrespectful of them. Okay, but again, even if we didn't have a personality disorder, if we were in the hospital and we saw nurses chattering and whispering, most of us may think that they might be talking about us. Otherwise, why would they be whispering? Okay, so if you need to talk about things, you need to do it privately. Okay, schizoid. Since these people do not desire socialization, do not force patients to socialize, assist in developing closeness to one person, for example, a case manager or one nurse. And generally, as a general rule, nurses should tend to have the same patients day after day. Now, that may change. One nurse may call in sick, so you have an extra 2 patients or 3 patients, or you have a discharge and an admission. But as a general rule, it's best to have the same nurse taking care of the same patients on a daily basis. Schizotypal, assist patient with social skills and hygiene, as this will help in socialization. Again, this is pre-schizophrenia, so they may not be taking care of themselves very well. They may have a lack of hygiene, things like that. Antisocial, again, limit setting is very, very important here. Confrontation of deceptive behavior immediately. Again, when a patient goes in a room and steals cigarettes, we have to address that immediately. Again, just like with your children, you don't discipline something your child did 2 weeks ago. You would deal with it right then and there. Okay, getting back to borderline here, we want to reduce the likelihood of self-harm, so we can do a safety contract that the patient will not harm themselves. Encourage identifying and expression of feelings by talking and journaling. We've spoken about that. We want a limit set on monopolizing the nurse's time. These patients can want to monopolize our time, and we have to put limits on that, saying, Mr. So-and-so, I've spoken with you for 10 or 15 minutes. I need to speak with other patients. If we don't do that, that can be perceived by other patients as favoritism. So again, we treat every patient fairly and equally across the board. We can teach these patients effective communication skills. We can help them restructure cognitive distortions, as I've said, help patients structure time to avoid boredom and perceived rejection. Again, when the wife goes on a business trip, what can he do next year, this patient, to avoid this feeling of abandonment? Histrionic, give appropriate feedback concerning social interactions to decrease excessive emotionality and attention-seeking behavior. Okay, hysteria, histrionic. Narcissistic, we want to set limits on rude, attention-seeking behaviors. Avoidant behavior, cognitive restructuring of self-criticism. These people tend to be critical of themselves. It might be said they have a punitive superego. Explore and reinforce positive self aspects. Okay. Dependent, assist patients in identifying strengths. Restructure, again, cognitive distortions. They have empathy. They're good caretakers, something like that. Help client learn how to problem solve. Again, this way they're not dependent upon other people. A very simple way to do this is making a list of pros and cons of a situation. In fact, I think all of you did this a year or 2 or 3 ago. You were somewhere in your life saying, I'm not satisfied. I want to do something more with my life. Do I want to be a doctor, a lawyer, a nurse, a social worker? You probably sat down either in your head or on a piece of paper and made a list of pros and cons of each profession. And I just want to say, I think you made a great choice in becoming nurses. Okay. Obsessive compulsive here. Cognitive restructuring, help client, and I / student, laugh out loud if you see that, to accept less than perfect work. I know you guys want great grades. I know it took grades to get in here. But if we always are disappointed when we don't get an A, we're going to be disappointed in life, okay? So as my dad used to tell me, lower your expectations and your happiness will rise. Now, we're going to shoot for A's, but if we don't get an A, we get a B, or for that matter, even a C+, we say, I studied as hard as I possibly could. I have another full life, children, husband, work, things like that. I did the best I could. So be kind to yourself. Okay. Help client enjoy process, not the product. And again, this comes down to very important in nursing. If we always need a product to feel good, when an addict who I've treated maybe in a rehab goes home and shoots heroin or drinks the next day, I could feel like a failure, okay? But I'm not going to take that personally. I enjoyed the process of working with that person, okay? We want to help the client relinquish control and responsibility, that they don't have to always be in control. They can relinquish that to other people. And again, there it is, lower your expectations and your performance and happiness will rise. And I want to say that this actually came from an organization called Recovery Incorporated. I don't know if they're still around. It was started by Dr. Loeb, I believe, back in the 50s or 60s. It was still going in the 80s. They meet probably once a week. You could probably go online and find this organization. It really is for people that have anxiety disorders. Conclusion. Patients with personality disorders can be very frustrating for staff as they do not appear ill. They do not see themselves as ill. They do not respond well to treatment, particularly medication, tend to blame others and split staff and want to be treated special. Interventions must be repeated with patience time and time again. It takes a very firm but fair nurse to handle these patients, and once again, they should ideally have nurses that are specially trained in this area, and psychologists and social workers also. Okay, there was something I wanted to go back to. Let's take a look here. Well, I forgot about it. But anyway, hopefully this took not quite as good as the TV, but I think it did pretty well. Hello there.